Good morning and welcome to this Grant County Opioid Fund Committee meeting. It's December the 15th and it's 9:01 a.m. Today the prayer will be led by Mr. Poling with the Pledge of Allegiance led by Mr. Lemming. You would stand.
Lord Jesus, we come to you this day and ask you to guide us in the county's affairs. Let us help more people than we ever have. In your name we pray. Amen.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, gentlemen. This is a newly established committee by the commissioners. The committee was established through ordinance number 12, 2025. Should we go ahead and do a roll call?
Garcia.
Here.
Parker.
Here.
Lemming.
Here.
Poling.
Here.
Middlesworth.
Here.
Stewart.
He did say he was going to be late.
Frankel.
Here.
Jarvis.
Judge Meeks will be late.
Thank you. And so if you would, in your packet and as well as electronically, you should have received the ordinance, ordinance number 12, 2025, that spells out this newly established committee. And you can see in section 4, it talks about, who the committee represents: Grant County Commissioners, the sheriff, 2 members of the council. The president should serve as the chair and a judge of the county. And if you move on to the duties of the committee, number 1 is conduct a local needs assessment using publicly accessed data, whether that's from overdose deaths, emergency department visits, etc. 2, develop a strategic spending plan that authorizes, prioritizes evidence-based and promising practices for the opioid abatement. 3, ensure compliance with Exhibit E of the National Opioid Settlement Agreement and state regulations. 4, recommend procurement, contracting, and monitoring practices and ensure compliance with required state reporting to FSSA under IC code 4615. Establish performance metrics and require outcome reporting from funded programs. Provide regular updates to the Board of Commissioners and public on all fund allocations and program outcomes. So that kind of gives you a brief overview of the duties of this committee. And I'll go ahead and turn it over to Mr. Parker.
Thank you, Mr. Middlesworth. In going through those duties, we're going to deal with some housekeeping matters. And we're going to circle back to those duties again on number 9 on the agenda, which is priorities and what are our next steps. Ordinance is pretty clear as what the community would like to see done in the way of research to help advise them on how to spend the money that counties will receive through the various opioid settlement matters that are going to provide a lot of funding in the next several years. So
currently, just for the record, in the 1237, the opioid restricted fund, there's a cash balance of $811,886.59.
that's in the restricted?
In the restricted. And then the unrestricted, the current cash balance, including investments, is $385,728.68. And then currently, there is a budget, um, and called, opioid restricted fund 1237. And currently, for next year, there's a budget of roughly $135,376. And that's, for salaries.
So we'll, look at the base dollars that we're starting with. There's going to be a lot more. So we'll just trying to figure out what the best use of those funds are going to be, knowing that there are some restrictions on 2/3 of those funds. We're going to look at that later. As far as item number 3 on the agenda, this is a public meeting, so minutes be recorded. So we'll be providing those. The auditor's going to keep those for us. Yes, part of commissioner meeting. So everybody will have those. Next item is the meeting schedule. We scheduled this at 9 a.m. on the second Monday to keep consistent with the commissioner's schedule. So the 2 times we have available, we think would be preferable for the committee to continue to meet beyond that second Monday, but either at 9 a.m. or at noon, depending on what everyone's schedule preference is.
This time I'll just go ahead and open the floor. Is there any questions or comments, or did anyone like to see the 12 o'clock noon meeting on the second? The 9 a.m. works best.
We got a judge though on there, right?
Right, the judge isn't here, so
So you've got to, I mean, I think that's why they always made it at noon, right? So it didn't mess with their court,
it might be easier for him at noon.
I'm saying.
Yeah,
So we could tentatively do it for noon, check with Judge Meeks,
okay.
and okay. They'll join us this morning, but if not, we'll circle back to that. The next item is the open door law. We discussed this is a public meeting, so the public door laws, open access public records laws will apply. And that brings us to, and I believe everybody has a copy of Exhibit E, which is the additional settlement standards for the use of opioid. And these are published in the file. So things that has that information for their review as well. And the next document you guys have is the state law, which applies and governs the, and also state code, state guidelines that are hidden. So this is the purpose of giving all of this up front, is because you can see we're operating framework here. In order to figure out how to best use the money, we've got to figure out the rules, figure out the framework, and then let that, along with our data we're counting, begin to drive where our solutions go. So that brings us to number 8, which Mr. Mills has already covered as far as the dollar amount. Looking at so far, we've never come. Yeah. Having explained all of that and those items, I think it's appropriate for us to discuss some of those, any of them, and also begin to discuss how to develop our priorities. The duties of the committee listed in the ordinance. So, going through at least initially, why we're here and all the items that we discussed. Although all of you decide where you take it.
No, absolutely. I mean, obviously, the goals of the commissioners is to make sure that we're maximizing all the dollars that we have available through those metrics that obviously the state has put forth. And obviously, when it comes to unrestricted, those dollars are not restricted in any such manner as Exhibit E or the guideline of the 1535 or 15 you see in your packet. So I think, like I say, the goals of the commissioners is to make sure that we're utilizing those dollars to actually help people that have suffered from those opioids within our public. And so we want to make sure that any way we can to maximize the dollars. And I don't speak for Commissioner Polling, but I know that we just want to see the funds be used more and try to just help. I mean, if anybody else has any other questions or comments? When is the count?
It varies.
There's no one time.
It varies.
I don't know how many more settlement payments we'll receive. But I know that we've signed 2 this year.
Pharmaceutical companies constantly are being sued and they just keep racking up.
What has been the frequency of the
It's
distributions? Any memories?
Random, I think.
You want to come up, Melissa?
Oh, I,
Yeah, one of them.
Yeah, Melissa, if
Yeah,
you
you
would
usually have a better.
just give us an overview of where the committee had been and then.
Sure. So similar to some of the discussions that you guys are starting to have is looking at prioritizing funding. So looking at what can we get with grant funding? What can we not get with grant funding? What's been proven to work? What's not, what don't we want? What do we want to stay away from? So we didn't want to use any of the funding for things that you could get grant dollars for, because you can usually get those. And so there isn't a rhyme or reason of where the money comes when it's just kind of like you get a notification and hey, it's here. There was a long delay from the initial settlement in 2020 to when we actually received them. So
too is when we first started to receive.
yeah, so there was a long delay. So you can imagine the ones that are getting sued now, you're not going to see that money likely for a long time. Sometimes those pharmaceutical companies are settling for a lesser amount than what the settlement said. So there's a lot of moving parts. So it's kind of hard to predict like what's going to be coming in and how to make sure that you don't overspend or underspend. So we've kind of taken kind of a slower approach about because you don't want to start something and not be able to keep it going, and so that's why we were thinking initially this was the first round of settlements that the 2 positions that are in there now came from, and so we were looking at long-term sustainability of that to relieve pressure from the county a little bit about things that we know are effective. Happy to share. I know you mentioned outcomes and program outcomes, and there's 2 positions. And what we do know is that our most recent drug court evaluation looked at recidivism rates. And the 3-year recidivism rate for our drug court is 10.9%. compared to 64%. So that's kind of the control group. So the control group looks at people who could have been in drug court, but there was no space. And so we follow them all the way out to see what their recidivism rates are. And then we also follow our graduates to see how are they doing after they get out of the program. So huge difference in recidivism rates based on availability of programming for them. So
do they have numbers where like how many people, say for the last 5 years went through drug court? And then how many actually succeeded after 5 years?
we do 3-year recidivism rates, which is very conservative because some jurisdictions only do a year. But we really look at, 3 years, how well are they doing? So we have all of that data. We actually pay for an outside evaluator from Indiana Wesleyan to come in and look at that. We track as soon as they get arrested. We will.
So I mean, like in 3 years, you had 300 people go through there and, you know what I mean?
So statistically, you'd have probably 33 get rearrested.
Right, but can we see those numbers? How many people actually went there for 3 years and how many's actually completed it and finished it?
Oh, you mean like program retention? They come into the program and they
I
graduate?
mean, like if you had 300 people in that program, and then at the end, how many actually succeeded?
Yeah, we track that. Yeah. Yeah. So we
I
track.
can see that.
Sure. Yeah. We have, we look at the retention rates. And
Right.
so, in terms of how well are we retaining people? So if 300 people come in, if 150 complete, then we know we've got a 50% retention rate.
Right.
So, we track all of that information.
Those are the ones you track. The ones that completed the program are the ones you track for the 3 years, correct?
Yes, we do. Actually, both. We track the ones that.
You have to track how many you put in there, right, all the time, so you have your number up, right?
Yeah. So we track. We can tell you the 10.9% recidivism rate for those who graduate. We also can tell the recidivism rate for any person that's ever been in the program. The difference is most of the people who are in the program and they commit a much more significant arrest, they end up being terminated. So it double counts,
Right.
It's like,
So what's the percentage of the people who don't complete the program that reoffend?
yeah, I can look because we just had our evaluation. I can bring that to you guys because for many years we've been able to see that even participating in the program itself, they do better than the control group anyway. And most of those are being terminated because of a more significant arrest. So even if they get arrested for like a possession charge and they stay in the program, it counts. So it gets a little,
Numbers are tough.
yeah, math is hard.
I understand, but it's a good source of data.
Yeah.
This whole discussion is just the first thing. The first duty is how do we conduct a local needs assessment? We've got to put our data together.
Yeah.
So I'm trying to keep a list of things that what my goal is try to come up with after discussion today. We can circulate an email, figure out what we think we need, and from obtain the information and have that hopefully by our next meeting. If that sounds like something, at least one thing to accomplish today.
Now, do you know what the long-term success rate is in 3 years? The reason I ask is because I have a friend of mine who's had an addiction problem, and he would go for 2 or 3 years and fall off the wagon. It was just a constant. So I think it's important to have long-term success because 3 years really is not really that long of a time period. So it would be interesting.
That's the same way about keep straight for 2 or 3 years.
Yeah, and then all of a sudden they just fall off the wagon and go back.
I think a lot of the drug court data is going to be helpful. I think we need to get methadone clinic information as well to see what
Do you think that's a good thing or bad?
So medicated assisted treatment can be really helpful for people who are looking at long-term recovery, so addiction kind of rewires the brain. And so that can help create some kind of some stability as people are navigating recovery. I would encourage you to also look at maybe groups, which is the Suboxone Clinic. And Radiant Health also is certified to dispense medicated assisted treatment too. So they would also have data
Okay.
looking at that.
Is Suboxone and the methadone clinic, is that ran by the government or is that
I
private?
think they're private.
Yeah, Methadone's their own company.
Yeah, but
Methadone.
they have public, reporting requirements. Well, they have
Well, I
public.
know a lot of people I know that told me they went in there and they kept them on the highest stuff, you know what I'm saying? Really never tried to step them down.
That's kind of what we look at it. To me, it appears we're trading one addiction for another.
Yes.
I mean, that's what it looks to me just on the surface. Could it go deeper than that? Obviously, it probably could. But I do know that we do still have a lot of issues, even with people coming from outside of the county to our methadone clinic that cause a lot of issues for the citizens here of Grant County. So one of the things that I do know is that those with the addiction problems on their own aren't knocking down the doors of these rehab centers, because if they were, we'd have rehab centers all over town. And then another thing is that those that we deal with in the jail oftentimes don't have a good support system at home, or their families can't afford to send them to a rehab, and they don't have insurance. So the problems we run into is we have people that have addiction issues that maybe don't qualify for a drug court. So they're kind of left behind. That's why I think when we're talking about priorities, I think one of the things we want to look at is what can we do for those that are incarcerated that don't qualify for drug court. And one of the things that we're researching now is to try to get a number of how many we actually have that have addiction problems, because our number is going to be different than what the national average is going to be. I'd like to say, okay, at the Grant County Sheriff's Office, we have 380, let's say 380 inmates. Out of the 380, we have 150 that have addiction issues. I think it's important that we have a solid number of who we're talking about that needs the help. So what we're wanting to do, we had JADM Ontario put together a program that we definitely like to bring before the board at some point to get an individual in to do those things at the jail, kind of like a social worker within the jail that would be able to assess our inmate population to find out, is it a drug addiction? Is it a mental health issue? Is it co-occurring, or whatever they call it, a little bit of both? We think it's important to have a foundation as far as how many people we actually have. And then this person can direct them to the different programs that are out there and be that liaison person that can do that.
Here, let me ask you something. When you have like somebody that's addicted, right? You have them in jail, coming down or whatever. Do you have to give them medicine or bring somebody in to give them medicine?
Now, the only time we do is if they're prescribed by a doctor, then we continue with that prescription. We don't do that.
I was just wondering because, just like the opioid, the methadone clinic, right? And when my daughter got involved in all this, I did a lot of research, talked to a lot of people. Almost every person I ever talked to that beat it, they went to all the rehabs, all that. They said the only way they beat it is didn't take nothing. And they said about killed them. They said, and all them guys are the only ones that beat it.
Well, I can tell you that that's been a big conversation at sheriff conferences on doing those things. We don't do it here.
I'm just saying.
We're just mandated by states that if it's a prescribed medication, we don't have an option. We have to continue it, but we don't have any of those programs.
And I'd say we have a lot of them going through their cold turkey too, is what I'm saying. And like when they're waiting on pre-trials and stuff, right? If we could get them in, got them there, then get them to it. You know what I'm saying?
And that's what we're wanting to do with this.
Thinking right.
With this position is we can have someone that can coordinate all those things and put them in different programs, and then kind of do what you guys are doing, able to follow them afterwards to find out what our success rate would be. because I think it's important that we realize that the majority of people with addiction issues aren't looking for help until, unfortunately, they hit rock bottom, and sometimes rock bottom is a jail, and then we're able to send them to programs like drug court or other programs that are out there. So we feel that it's important to have something in the jail while they're there, that we can get them through these, at least somewhat of a program within the jail, so that we can get them additional help outside. But all that obviously requires funding. And so I'll have Dr. Monterio, she's putting something together, and if you guys would love, I'd love to have her come and present something to the board.
Yeah, I'm working on something too, because the way I look at this, Sheriff, I understand what you're saying in the jail. We have a lot of people sitting in there for pretrial. That could be at a place, taking that instead of putting that on the taxpayer. And you can get, there's a lot of grant money, way more grant money than we know for this stuff. Isn't that so?
Well, we've tried
Times, yeah.
we've tried to get people at different locations, and unless they have insurance or a way to pay for it, we've tried Bowen Center, Radiant Health, we've tried, and we have had some success with, there's a place in Hendricks County. And sometimes what our medical provider is able to do in the jail QCC is they're able to get them the state assistance to help pay for it. But for some reason, not everybody always qualifies for that. And I don't know why. So we do try to do some of those things, but it's the for-profit organizations that make money, unless they have insurance or someone's willing to foot the bill. I mean, a lot of times we don't have very much success getting them in the programs. I mean, we've tried here at Radiant Health, we've been turned down.
I've reached out to some bigger.
Yeah, we've tried Bowen's.
Just wait.
I mean, we have one guy now that Radiant Health is no longer wants to deal with them, so we're trying to get him put at Parkview. His co-occur is both medical or mental and addiction, and he's one of the guys that gave us about 70% of our workman's comp in the jail. So we're trying to get him into Parkview, and we're working with Radiant on this. They're trying to help us get him into a program at Parkview, but it is very difficult if they don't have insurance or they don't have someone that can pay that money. So that's why we think it's important that we have someone that's all they deal with, finding resources, finding programs, having programs within the jail to kind of tackle some of these issues because we're paying for it one way or another. So,
Melissa, you mentioned that you're being really conservative right now with your funding and restricted. As of today, what kind of the restricted funds being used for primarily?
So it's two positions. One is it allowed the drug court to increase its capacity. So it's a drug court probation officer. So we can see that even at the increased capacity, they're still performing really, really well in terms of recidivism rates. And we can look at, like I can bring you the data about substance use. So at graduation, in program entry, there's a lot of substance use. When they get close to graduation, there's minimal or none, and so really looking at the improvements along that continuum. They're getting access to care. And so addressing some of the things that the sheriff's mentioned about what he's seeing in the jail. Statistically, 95% of people who are incarcerated come back to the community. Whether we want it or not, they're here. When they come back to the community, they're usually with us. And so what we're seeing is if they're not treated, people act like they're not treated. That's what happens, right? And so the other position is we call a treatment coordinator. And this individual helps to get people into inpatient, residential. So while they're on community supervision, they're likely having substance use issues. They're having some recurrences of whether it be mental health, whether it be substance use. And they get to a place where they're saying, I need services, more services than what I've been getting. So historically, with the lack of seamless transition to another facility, they would sometimes most likely go into the jail while we sorted things out. Well, this position allows us to have some more discretion about saying you are ready for services. And then this individual actually will contact providers and facilitate transport transportation to get them there, bypassing the jail. And so it gives them a much quicker response to services. Research would say that the sooner you get to your response to the crisis, the more likely they are to stay in recovery. And so by having this person, they could be in services in a facility within hours rather than days, weeks, as they go through the violation process. And so we handle it differently that way because they can get into generally somewhere in the state, but there are a lot of treatment providers that our coordinators really versed in and able to say, this one takes private pay, this one takes state insurance, and so he's really good at being able to say, this is what they treat there. And so he works to get them into those services rather than trying to send them through the jail and hoping for the best. And then they also do, we do a lot of in-house groups. And so they facilitate about half of them. And this is a peer-led, this individual has lived experience. And so it's not somebody who's a certified probation officer or anything like that. So they have lived experience and can relate really well to the population we're serving. And so we've been able to provide a little over about 3,000 additional interventions through the in-house groups over the past year. So
Did you ever rotate those people, or how long do they stay there?
where?
The peer people. Do they stay there for years, or do you ever bring different peer people in to change them out?
Oh, so this I was referring to the person that's the treatment coordinator has lived.
I mean, like, I know my daughter and nephews,
Uh-huh.
and you have to peer people, right? Do those people stay there for years, or do we change them out every so many, you know what I'm saying?
Yeah, so the peers that are assigned to problem-solving ports are Radiant Health employees. So the ones that we encourage people to give back, and so some people are willing to come back and kind of donate their time to serve and work well with people, so we can make those connections.
I just wondered if you get, you know what I'm saying, change it up, get a different view after,
Yeah.
get people in there for 5 years, get, switch a couple of them up or something.
Yeah. Generally, the ones that are assigned to problem-solving courts aren't our staff, so we're kind of at their mercy of who they place there. But what we've started noticing, there are two domains that we measure with those in-house groups too. One is their cognitive improvements, and one is a behavioral improvement. So the number one dynamic predictor of future criminal behavior is how somebody thinks. And so we're measuring both of those. Along the continuum of, we looked at 3 different facilitators, and all 3 of them, based on this pre and post data, have seen improvements in all 3 of those. So they were consistently showing an improvement of cognitive, like the way that they're thinking is improving, and their behaviors are improving. And so that's really encouraging as we think about like evidence-based programming and things like that. We've had some conversations about kind of trying to make a seamless process between jail release and services that are there to community supervision, instead of saying, we'll start this program, but if you get out, it's not finished, right? We know that most of them that are getting out are going to be coming to us. So we've talked a little bit about making a similar program, so that way when they get out, they still have a place to plug back into. So thinking about long-term, getting services while they're incarcerated, but also maintaining services when they're in the community to help kind of bridge any gap. Or all of our in-house is free. We got grants for materials, so the barrier of insurance or money isn't there. So it's really trying to remove all the barriers to services that we can, and still give them what they need. These are the programs we're doing are designed for substance use, and some of them are co-occurring substance abuse and mental health. So all evidence-based, not something that we just decided, sounds good, let's go for it.
And you're currently doing these programs?
Yeah. The treatment coordinator does about half of all of those groups. And so that's also a position that kind of is in there as well. So we've leveraged what he can handle. So he's still able to get people into treatment and services, but also help kind of with the treatment education and services that still fall in alignment with what you're supposed to be using that funding for.
Is he working through the drug court? Is that what he's doing, treatment for?
He works, he is on the drug court team, he's on the reentry court team, the mental health court team.
So most of the people he's dealing with have been through either drug court or reentry or?
So he also works a lot, so he can have anybody that's on community supervision, so they could be on house arrest.
So these are ones who've already been through the system?
They would have been sentenced
Right.
at that point, yes.
So are we doing any, I'm gonna I'll tell you a story real quick. I'm trying to be quick. Some of us went down and toured the Hancock County Jail a couple weeks ago, some councilman and Mr. Millsworth. We met with their sheriff, we toured their jail, and they were in a similar predicament as we are now, with an older jail, overcrowded, recidivism rate was extremely high. And they made it their priority, once they built a new jail and they moved out there, they had additional classroom spaces. So his philosophy is, if I get them in jail, I can treat them because I have a captive audience. And he says, we found that our success is largely due in part because when they come into jail, we meet with them right away. And we decide, okay, what's the issue here? What do we need to deal with? Their recidivism rate I think now is like 17%, if I remember right. So they're doing some things tremendously well down there. And it was a very informative trip for me because it kind of opened my eyes as far as this is what can be done because they're doing it and they're making it work. And he's offered up services and talk. I don't know that it's necessary or not, but it's just, I wish that all of our guys could have been there because it was really, really informative. But his philosophy is we've got to get them, as soon as they come in the doors in the jail, we meet with them. We have groups, we partner with outside churches and all this kind of stuff, and they have professionals come in, meet with them, decide is this mental, what kind of condition do we have going here that we need to tackle? I thought that was really neat that they figured out a way to get the recidivism rate down to pretty much an acceptable level. And they're doing it when they get them in jail. As soon as they get them in there, we're working with them.
And that's kind of what we're wanting to do with this. I call it social work just because I can't think of a better word for it, but because that'd be their first thing they're going to do, assessment of every incoming in. The first assessment they're going to do is everybody that's in the jail. Where are we at numbers wise? And that'll be probably pretty difficult and time consuming. And then we'd move from there that as soon as someone gets incarcerated, they would do an assessment and then determine where we go. I think the key to the whole thing is space, right? You have to have space to provide these programs. Because what they do is if you're in a group, then you're separate from the other population. They normally try to keep everybody that's in these programs together in the same cell block. So you have to be able to provide that space. But yeah, it's definitely something that's doable. We just have to be willing to provide the space and get the facility to do those things, because he's right. You have a captive audience, and then it really works well with probation, because once they get done and get sentenced and they go from one program to another program, and it's just not, because once they get out in the world, in the real world, a lot of times you'll see they go back to the same environment they were in, and that's why they struggle. So we can catch up early and continue putting them through services. I think it's more effective than just sending them out, putting them on probation, and they're kind of battling with being with their friends and being on probation and going through the program. So, I think that the key is space. Is how do we create space to do those things?
Mr. President, what I can do is I've been putting together a list of people, of organizations, which we should seek information I can draft a letter on behalf of the committee. I want to go through them to cover a couple of things. I think obviously we need to send them for drug court, perhaps even to community corrections, to Radiant Health. We need to either ask the method of or see what is publicly available information there is. In my opinion, part of the opioid problem also stems from an economic problem as well. And so I think we should get some poverty data. The Community Foundation is very good about keeping track of that. We can get information from them. I'll be able to get employment data from the workforce development to see what our job numbers are looking like, to try to contextualize this. 1/3 of these funds are unrestricted. In my opinion, probably the best thing we can do is try to do things to help from an economic perspective, help lift up our community overall. And then I think to Mr. Frankel's point, we need to begin reaching out to Hancock County, try to see what kind of information that they have. Obviously, the sheriff has indicated his willingness to work with us, so I can put together that and hopefully have that letter set out. My goal would be to send a draft out, either to you or the committee members, whichever your preference is, to get that information sent, or get the correspondence sent, and have the information back in time for our next meeting. We had discussed the second Monday of the month. We did not discuss whether we wanted to do monthly or every other month. I think I initially had considered, we talked about doing on the even numbered months. So since we met in December, our next meeting could be February if we want to keep on that schedule. Given the amount of work and hours at stake, I think they're in good shape right now, probably meeting every other month. There's certainly a lot of information that's been provided today as far as what the rules we're getting into. But once again, I'll open it up to discussion on that. That would be my suggestion at this point.
That would tentatively be February 16th, depending upon whether, I think Judge Meeks is probably the guy with the most schedule restraints, so.
Sure.
I think that sounds like a great plan to me. That's kind of step one.
Yeah, I think our first step is we gotta get as much information as we can. I mean, we've all lived with this problem for a very long time. And so
16.
this committee is to see what we can do to address it.
Data, so I can send out.
So we'll meet February the 16th.
Oh, so 17th, excuse me, 17th.
17.
16th is President's Day. Thank you, Greg.
Oh, it is.
So we're meeting every other month?
Even number months.
Yes, 17th.
You'll send out an invite.
I will.
Probably, we'll try to send them out. We'll speak to probably Judge Meeks, we'll send them out for the year. We'll include you as well.
These are public meetings, so we'll have to notify.
Yeah.
Is there anything else for the good of the order? At this time, I'll go ahead and open it up for public comment. If there's anyone from the public that'd like to address the opioid committee, come to the podium and state your name and address for the record. Anybody online? Is there a motion for adjournment?
Second.
Motion from Mr. Lemming, a second. For adjournment, all those in favor signify by saying aye. Aye. All opposed, same sign. Motion carries. Thank you.
Another meeting.